Welcome back to the American College of Surgeons Bulletin Brief from the Front Lines, Surgeons' Voices. Today I have with me Professor Elizabeth Wick. Professor Wick is Professor of Surgery at the University of California in San Francisco and a renowned outcomes researcher. Welcome, Dr. Wick.
Thank you so much for having me.
My pleasure. I very much enjoyed reading the article, which I found in a pre-proof state in Journal of the American College of Surgeons about the feasibility of enhanced recovery in emergency colorectal surgery. Knowing that not all of our viewers and listeners are general or colorectal surgeons, perhaps you could start by explaining enhanced recovery protocols.
So I think enhanced recovery has been one of the great innovations in quality in surgery in the past decade. And it's an approach to thinking about the journey of the patient from the decision to operate till when they come to surgery and when they recover on the inpatient unit and transition back to the community, and thinking about what is the evidence for each phase of care and standardizing that evidence and holding yourselves accountable for the evidence and really putting patients on a care pathway. I think it's been largely responsible for significantly improving outcomes in colorectal surgery with spread to elective urology, gynecology, other pelvic surgery, and beyond. But it's really been focused on elective surgery. And in this paper, we start to explore whether some of these principles could be applied to emergency surgery as well.
The enhanced recovery programs or enhanced recovery pathways have multiple components, some of which are implemented prior to surgery, some during surgery, some after surgery. Perhaps you could give us a couple of examples of some of the components or elements of these programs.
So they've really focused on patient and family engagement, setting patients' expectations prior to surgery and making sure they're well educated, prehabbed if possible, as well as focusing on multimodal analgesia when they're in the hospital, avoiding opioid analgesia if possible, controlling fluids, early mobility, and ensuring optimal nutrition. And again, they span the whole continuum of care with a lot of this focused in elective surgery on the inpatient phase. And so that's as we've thought about moving it to emergency surgery, that's sometimes been a stumbling block because you don't have that opportunity to set expectations.
That was going to be my next question. Exactly. You mentioned rehabilitation, you mentioned education, you mentioned family engagement, but yet in the emergency setting, which was your paper, you didn't have that opportunity. So in a moment, I'm going to just ask you to describe the results, but hold that thought. And first, if you could please tell us the involvement and role of the American College of Surgeons in you and your colleagues being able to accomplish this study.
Yeah, so we were really fortunate. The data that was used for this study was collected as part of a national collaborative that we've been running that's funded by the Agency for Healthcare Research and Quality and is a collaboration between the American College of Surgeons and ACS-NSQIP and the Johns Hopkins Armstrong Institute for Patient Safety and Quality. And the collaborative launched in 2016, and it's been a learning collaborative around implementing and accelerating the adoption of enhanced recovery practices across the US. We focused on colorectal surgery, gynecology, and orthopedics in our first 3 cohorts. We're just starting our last cohort now where we've added general surgery. And all the hospitals that participated have implemented enhanced recovery programs and collected both process measure and outcome data through their participation. And as part of this study, we went back and looked at the hospitals that have been participating in colorectal surgery because we'd seen a sort of interesting observation that while most hospitals initially focused on their programs on elective surgery, as hospitals and physicians started to think that, gosh, these are just really the best practices for all of our patients, they started to add emergency patients to the registry, and we started to see those popping up more and more, and we wanted to look and see what really the feasibility of the pathway was for that complex patient population.
Thanks very much. So clearly the American College of Surgeons was behind the trial or the study that got undertaken. Would you be able to also share with us some of the results, what you found?
Yeah, so we found that, the compliance For the elements after the patient gets to the hospital, so not including the patient education and the things that happen in elective surgery, but once the patient gets to the hospital, as the hospitals were starting to put these patients on their enhanced recovery pathways, we saw that the compliance was really quite high. Not quite as high as elective surgery, but not zero. And some factors were high, such as VTE prophylaxis and early Foley removal. And we saw over time that multimodal analgesia increased. And what we also found was that as patients had higher compliance with these process measures, and again, it got down to a smaller subset of patients, we saw improved outcomes, suggesting that this is a feasible approach and something that more and more of us should consider as we try to tackle some of the most complex patients we take care of.
Well, thank you. One of the interesting findings was that compliance seemed to be less in younger patients. I believe it was under age 65, which to me seemed counterintuitive. Do you have any explanation why that might have been the case?
We don't have a good explanation. We have a very limited data set, and it was really about feasibility. But it may, as we get more data with the upcoming cohort where we're collecting, where the hospitals are specifically collecting data on emergency general surgery, hopefully we'll see that unevenness sort of addressed and all patients getting the data. Because again, this was sort of a happenstance and a byproduct, and the hospitals weren't required to enter data on emergency patients. It just they happened to.
And the other finding that is perhaps more intuitive is patients in whom there was less mobilization enforced, or patients mobilized themselves less, and patients who were not offered liquid diet as quickly had a longer ileus. And of course, one wonders if they weren't given liquid because somebody thought they had an ileus, or they, therefore they didn't want liquids. It's a bit hard to know. But what are the options we have for improvement? In other words, what are some of the lessons learned that might help us out from those areas with mobilization, liquids, younger patients?
Yeah. Well, again, I think trying to think about opting all patients into the pathway, and then slowly, if they start to look like they're not progressing, to take them off of the pathway, as opposed to just select patients that look well enough for the pathway. So sort of inverting our thinking. Actually, the project just had a great call this past week. We have a series of national leader webinars for hospitals that are participating, and Dr. Hina Santry, an EGS surgeon at Ohio State, spoke, and she reiterated that for EGS, we just need to think that we can give this evidence to every patient. And then if they declare that they get too sick or their trajectory changes, just back off. But we should expect that we can provide this to all patients.
What about when we get out of the realm of general or even intra-abdominal surgery? Because you mentioned urology and gynecology, but what about when we start looking at other areas, perhaps orthopedic surgery or neurosurgery? Are there similar pathways that are being implemented?
Yeah, orthopedics, gynecology, urology have had really great success with ERAS or ERAS-like pathways. And again, I think we're starting to learn that this is just sort of modern evidence-based perioperative care, that we need to educate our patients. We need to partner with them. We need to use multimodal analgesia. We need to get them out of bed. We need to ensure they have optimal nutrition, and we need to follow all the evidence-based guidelines in a standard way, and ultimately hold ourselves accountable for reducing variation.
We do a lot of patient education in different things. We tell patients it's important not to smoke, or check their A1C or colonoscopy, whatever it happens to be. And patients are given a lot of information before they go in for an operation. Is there public awareness, or as much public awareness perhaps as you'd like to see, about the importance of these pathways?
I don't think there's that much public awareness. I think, hospitals report that sometimes patients come in and ask for the ERAS pathway, but it feels like that's very rare. And in general, there's not awareness that there is so much variability in how you could be treated after surgery. There's much more focus on the surgeon, how many procedures that surgeon's done, and surgical technique in the OR, and much less consumer awareness on all these other factors that may have a big impact on your trajectory.
Well, hopefully, as you continue to look at areas like patient satisfaction, which are improved in part, less pain, less ileus, shorter lengths of stay, and the rest of it, hopefully it will be something that people learn more about. So what are your next planned steps? You mentioned you've got this national work group. What's the next project that we're likely to see?
Well, like I said, we just launched the cohort of hospitals. There are over 100 hospitals that are focusing specifically on their emergency general surgery patients. So not just emergency colorectal, all sorts of major abdominal emergency patients, as well as appendectomy and cholecystectomy, to really try to figure out how you adapt these pathways to the unplanned surgery. So thinking about what that pathway looks like when there's a lot more variation in how a patient shows up to the hospital, their physiologic condition, when we can't quite standardize that quite as well as we can with elective surgery. And again, to really think about how you can partner with patients and families when you don't have the advantage of that lead time before surgery. So the hospitals just started in September, and they'll be participating for 18 months, and we're collecting lots of data on process and outcomes. We have a great panel of EGS surgeons that served as a technical expert panel that helped us guide what data we're collecting. And so we're hoping at the conclusion that we'll be able to put forward some recommendations about what pathways should look like in emergency patients, whereas this study was just sort of a first exploration of what might be feasible.
Well, it was an excellent first study, and I think it's going to have tremendous impact. I'm looking forward to reading the sequel once it's out. Thanks for taking the time to be with us today and for sharing more information about this high quality study in Journal of the American College of Surgeons.
Thank you.